Hello. Good afternoon, everyone. Can you
Hello,
see the
ma'am.
slides?
We are not able to see the slides, ma'am. Not yet shared.
Yeah. I'll share it.
Yes.
Can you see now?
Yes, ma'am.
Yeah, okay, thank you. Good afternoon, everyone. I'm Dr. Durga, consultant in Tirupati branch. So today I'll be talking about the topic luteal phase support. So in this you will be learning about the understanding physiology of luteal phase. What is luteal phase deficiency? When does luteal phase deficiency happen? And situations in which luteal phase support is required, simplifying individual luteal support, and also indications for LPS, whether in natural cycles we need to give luteal phase or in assisted cycles, how to give LPS, all these things. And also to compare different agents which we use for luteal phase support, the routes, and the timing of administration of LPS, also to review the current guidelines as well as recent evidence, and also the practical protocols which we use in our center. So I'll be discussing all of this about luteal phase support. So before going into the actual topic, let us have a quick review of physiology, how it happens. You all knew about this, but just a quick recap. So what happens in a natural cycle basically is from day 2 of the cycle, the antral follicles get recruited. And after day 5, the selection of dominant follicle happens. Once the follicle becomes like big enough, around 17 to 18 around day 14 of ovulation, the follicle ruptures. And after early search, the ruptured follicles transform into corpus luteum. And the corpus luteum starts secreting progesterone. So if pregnancy happens, the corpus luteum continues to secrete progesterone. Otherwise, it becomes corpus albicans and it degenerates. So the main function of corpus luteum is to secrete progesterone, which is the main luteal hormone, which is critical for the transformation of secretory transformation of endometrium. So basically, before in the proliferative phase, the endometrium is proliferative. After the secretion of progesterone, it becomes secretory. So the main function of progesterone is it prepares the endometrium for implantation by stimulating the glandular secretions, stromal edema, and spiral artery formation. And the normal length of luteal phase is actually 12 to 14 days. So the corpus luteum, in addition to progesterone, it also secretes estradiol, relaxin, inhibin A, VEGF. These are the other hormones. And normally, for the proper luteal phase, in addition to progesterone, other hormones are also needed, like LH pulses has to be there to maintain adequate function of the corpus luteum during the luteal phase. In natural cycles, the same thing which I told, if no conception occurs, the corpus luteum regresses and within 12 to 14 days, and withdrawal bleeding occurs and menstruation occurs. But in conception cycles, the trophoblast cells from the embryo, they secrete HCG, which rescues corpus luteum, prolonging the progesterone until the placenta takes over. Like around 8 to 10 weeks, the luteoplacental shift occurs. So then the placenta takes over the function of corpus luteum. So, in order to understand about the luteal phase support, you need to have an understanding about the window of implantation. So, let us talk about endometrial receptivity and the implantation window. So, what happens in a typical 28-day cycle? Around day 20 to 24, like here you can see around day 20 to 24 is the implantation window where the endometrial receptivity is maximum. So after adequate estrogen priming in the proliferative phase, the secretion of progesterone begins, triggering a molecular clock in the endometrium. So this sets up a limited implantation window. So before this, the endometrium will be pre-receptive. After this, post-receptive. So only during the implantation phase, there will be maximum chances of implantation. So the luteal phase aims at creating a window of implantation to successfully cause implantation of the embryo. And the whole purpose of endometrial growth and receptivity is all targeted towards this one ultimate function, that is the secretion of progesterone, which is the most important regulator in the luteal phase. What is the role of hormones in the luteal phase? So the main hormones needed for luteal phase are LH and progesterone. LH totally responsible for steroidogenic activity of the corpus luteum. It also causes upregulation of growth factors like VEGF, FGF2 in the endometrium. So these are the factors which are favorable for implantation. And also the upregulation of cytokines which are involved in implantation. And also it causes stimulation of LH receptors in the endometrium. Whereas progesterone induces secretory transformation of the endometrium in the luteal phase, and removal of corpus luteum prior to 7 weeks even leads to pregnancy loss. So, what is luteal phase deficiency and why does it occur? Why does luteal phase deficiency occur is the corpus luteum fails to secrete adequate progesterone basically. So it leads to suboptimal endometrium. Only if there is adequate progesterone, it causes secretory transformation of the endometrium. So whenever there is inadequate corpus luteal function, it leads to luteal phase defect. So is there any test to diagnose luteal phase defect? So there is no single perfect test. Some say that we can measure serum progesterone levels around day 21 of the cycle. If it is less than 10 nanograms per ml, we can consider it a luteal phase defect. But there is no single perfect test to diagnose luteal phase defect. It is often a clinical diagnosis only. We can suspect luteal phase defect in people with like short cycles, short luteal phase, and the people with recurrent implantation failure or a history of recurrent pregnancy losses. In all these cases, we can suspect clinically whether if there is a luteal phase defect. The mechanism is defective corpus luteum leading to inadequate secretion of progesterone and disrupted LH support. So when does luteal phase deficiency happen? Does it happen only in stimulated cycles or it can occur even in natural cycles? So even in natural cycles, in 3 to 20% of the cases, we can see luteal phase defect. So in infertile couple, it is even higher, like 5 to 60%. The incidence is quite higher in women with recurrent pregnancy loss. So even in natural cycles, we can't ignore luteal phase support. We need to supplement with some form of progesterone to improve chances of conception. And in stimulated non-IVF cycles, like for IUA, for ovulation induction with timed intercourse, we stimulate. So in these cycles also, in 50% of the cycles, it is seen. So we need to give luteal phase support whenever we do stimulated cycles. And stimulated IVF cycles with agonist or antagonist. So normally in IVF, we do either agonist or antagonist cycles. In all cycles, the luteal phase will be defective. So in all stimulated cycles, luteal phase supplementation is mandatory. And especially in frozen embryo transfer cycles, when we give HRT, so there will be no corpus luteum in the HRT cycle. So in those cycles, we need to mandatorily supplement with the luteal phase. So these are all the mechanisms why luteal phase defect occurs in ART. So you need to understand like basically how we stimulate. Either we stimulate with antagonist cycles or agonist cycles in IVF. So in antagonist cycles, what we do is on day 2 of cycle, we start with gonadotropins. And whenever there is a dominant follicle, 1 or 2 follicles becomes dominant. And when estrogen rises, we start with antagonist. All this is to suppress the premature LH surge. And in agonist cycle, we give agonist from the like previous luteal phase, day 21 of the luteal phase till day 1 of the cycle, and then we start with gonadotropins. So here we need not give anti. So we do IVF either with agonist or anti cycles. Whenever we do agonist cycles, we cannot give agonist trigger. So we have to mandatorily give with the HCG trigger only. But with anti cycles, we can give either HCG or agonist, both we can give. Especially in agonist cycles, there will be a lot of suppression. It causes pituitary down regulation. So there will be defective LH secretion in the luteal phase. So obviously there will be luteal phase defect. What happens in anti cycles is it causes premature luteolysis. So there will not be adequate support in the luteal phase, leading to poor pregnancy rates. And in stimulated cycles, we usually will be stimulating multiple follicles and we will be aspirating all the follicles. So there will be multiple corpus luteum. And also the steroid levels from the multiple follicles, there will be lot of estrogen which will be secreted. So the hormone levels will be supraphysiological. So all this leads to negative feedback on the pituitary. So it causes decreases the endogenous LH. So this leads to defective luteal phase. And whenever we aspirate the follicles, it leads to mechanical disruption of the corpus luteum also. And when we give HCG trigger, HCG is a surrogate of LH. So it inhibits the endogenous LH secretion. So it contributes to luteal phase defects. These are all the mechanisms why luteal phase defect occurs in ART cycles. So can trigger cause luteal phase defect? Like will it be based on the type of trigger we give, like with HCG and agonist trigger? These are the two triggers which we use in IVF cycles. So HCG trigger, it mimics the natural LH surge because HCG itself is a surrogate for LH. It provides prolonged luteotrophic support because it has a very long half-life, like up to 7 days. The half-life of HCG is very long, up to 7 days. It supports corpus luteum initially, less risk of luteal phase defect compared to agonist trigger. Because with agonist trigger, the half-life is very short, like 24 to 36 hours. But with HCG, the half-life is long, so it supports in corpus luteum initially, and there is less risk of luteal phase support. But again, whenever we give HCG trigger, we should be very cautious of OHSS because in high responders, if we use HCG trigger because of the prolonged effect of HCG, like up to 7 days, it increases the risk of OHSS in high responders. So we should be cautious in giving. In high responders, we go with only agonist trigger and freeze-all cycles. So agonist trigger, it is short limited with a short FSH LH surge like 24 to 36 hours, and this surge is shorter and weaker than the natural or HCG induced LH rise. So it leads to early and rapid luteolysis and low estradiol and progesterone secretion. So with agonist trigger, the risk of luteal phase defect is higher. Whenever we give agonist trigger and we plan fresh transfer, it needs intensive luteal phase support. Like we should supplement both with estradiol, progesterone, with or without low dose HCG. So intensive luteal phase support is needed with agonist trigger. Or else we should go for freeze all strategy, so that we have to freeze all the embryos and plan transfer in the next cycle. So this is a very good image which shows LH surge in natural cycle with agonist trigger and HCG. So if we see LH surge in a natural cycle, it sustains for like 48 hours. But with agonist trigger, it is very short, only 24 hours. And with HCG, the LH surge is very long, almost till day 6, day 7, it will be there. So HCG trigger good luteal function, but risk of OHSS need to be cautious in hyperresponders. With agonist trigger, it is safer in high responders, low risk of OHSS, but it causes luteal phase defect without strong luteal risk. In order to understand LPS, you need to have an idea of fresh and frozen transfers. In IVF, after OPU, we do either fresh transfer or frozen transfer. In fresh transfer, what we do is we transfer in the same cycle. In frozen transfer, we freeze the embryos and transfer in next cycle. So in fresh transfer, we have to start luteal phase on the day of OPU itself or the next day following OPU. we'll start with progesterone supplementation, and then for the blastocyst embryo, we transfer on the day 6. In frozen embryo transfer, it depends on the protocol which we use for frozen embryo transfer. So these are all the protocols which we use. Natural cycle, it can be a natural cycle FET or modified natural cycle FET. It can be a HRT cycle, hormone replacement therapy, or it can be a stimulated cycle, or it can be a down-regulated cycle with GnRH agonist. In natural cycle, what we do is we just look for spontaneous ovulation and spontaneous LH surge, and from the time of LH surge, after 36 hours, we will start with progesterone supplementation. In modified natural cycle, we trigger with HCG, and 36 hours after HCG administration, we document the ovulation, and then we can start with progesterone supplementation and go ahead with the transfer. In HRT cycles, what we do is from the day 2 of cycle, we'll start with estrogen 2 mg TDS, or according to their endometrium. If it is thin, we start with little more higher dose. And whenever around day 10, we check the endometrium. And when the endometrium is more than 7 mm with good flow, then we start with progesterone supplementation, and we do transfer on day 6 of starting progesterone. In a stimulated cycle, we will give letrose with 1 or 2 doses of gonadotropins, this is called as mild stimulated FET. So we'll monitor the endometrium and we'll trigger and do 36 hours of the trigger, we can start with progesterone. So it is useful in irregular cycles, and patients who do not get endometrium in HRT, we can try with mild stimulation FET. And for few cases, we do GnRH agonist pre-treatment. Especially in cases where we don't get endometrium with HRT or natural cycles or mild stimulation cycles, then, and if it is polypoidal and in patients with endometriosis, in such cases we prefer to go with agonist pre-treatment, which suppresses the endogenous hormones, then start HRT, and then we can do transfer. So this is the same thing. In HRT cycles, whenever the endometrium is adequate, we'll start with progesterone. On the 6th day of starting progesterone, we can do the transfer. This is modified natural cycle with HCG trigger. So we should give the trigger 36 hours after, we should monitor and then start progesterone. So after HCG trigger, transfer will be around 7th day. Natural cycle, we detect the LH surge, then start progesterone. On 6th day, transfer will be there. We have a separate class on all the protocols about FET, but to have an understanding of luteal phase support, I'm just telling that. So what are the conditions where we have to supplement with luteal phase? All fresh IVF cycles with conventional ovarian stimulation with agonist or antag protocols, and all frozen transfer cycles we need to supplement with LPS. And especially with agonist trigger, we need to give intensive luteal phase support. So these are the indications for luteal phase support in ART cycles, all fresh and frozen transfer cycles, especially with agonist trigger cycles, we need to give intensive support. And even in true natural cycle FETs, corpus luteum will be there. It secretes progesterone, but still it will be suboptimal in few cases. So we will supplement with progesterone. And in special conditions like multifollicular growth with high gonadotropin stimulation, and patients with recurrent pregnancy loss with suspected luteal phase deficiency and advanced reproductive age. In PCOS patients, often the LH surge is altered, so there will be luteal phase deficiency. And in patients with endometriosis, in all these conditions also we need to provide luteal phase support. So what decides the luteal phase support? What to give, and we need to give more or we need to give less? How we'll get to know is like whether it is a normal cycle or hyperstimulated cycles, whether we have used agonist protocol or antagonist protocol, and the type of trigger used, whether we have given HCG trigger or agonist trigger. And basically LPS decides on all of these factors. So IVF fresh transfer with agonist trigger. Whenever agonist trigger is used in antac cycles, there will be less risk of OHSS. But because of the shorter half-life of agonist, there will be profound luteolysis which occurs, which can lead to implantation failure. And E2 P4 levels will be very low. So intensive luteal phase support is mandatory in agonist trigger cycles. So all the recent guidelines like H3, ASRM, Cochrane, all those say like LPS is mandatory in all IVF ICSI and programmed FET cycles. And I'll be telling you all the preparations which we use for luteal phase support. Vaginal progesterone is the first line according to H3, and oral dydrogesterone is an alternative. And in natural cycles also, routine LPS is not required, but we can supplement in selected cases. And with agonist trigger, intensive LPS is needed, or we can even we can even give dual trigger because HCG rescues the corpus luteum. And according to Cochrane, LPS improves live birth rate in ART cycles. Between different routes of progesterone, there is no much difference between oral dydrogesterone and vaginal progesterone. So, what is the goal of luteal phase support? The ultimate goal would be to achieve adequate endometrial transformation for implantation and maintain early pregnancy until placenta takes over. So, until luteoplacental shift occurs around 8 to 10 weeks, till then we need to give luteal phase support. And it should be kept in mind the OHSS risk should be minimal with the luteal phase support we give. So, when to start luteal phase support? It can be started after ovulation or after oocyte pickup in IVF. And till 10 to 12 weeks, we need to give and then taper. What are the drugs which we use for luteal phase support? So the mainstay of luteal phase support is progesterone, which can be used orally, vaginally, intramuscular, or subcutaneous. And the other things which we use for luteal phase support are estradiol can be given either orally, vaginally, or transdermal preparations. And we can give GnRH agonist. We can give certain adjuvants like ecospirin, low molecular weight heparin, steroids, IV immunoglobulins, intralipids. I'll be telling about all of them in the next slides. And even we can supplement with HCG also, but nowadays it is not much used. We can give both estrogen and progesterone combined. So progesterone is the mainstay of support. It can be used vaginally as suppositories, gel or tablets. It can be used intramuscular oil-based preparations, and subcutaneous preparations will be there in the form of acquesestin and oral micronized progesterone or dydrogesterone, which is synthetic progesterone. So, what is the role of progesterone in luteal phase support? So it has so many functions. It reduces prostaglandin synthesis, supports the endometrium, increases the level of CD blocking antibodies. It relaxes uterine musculature. It suppresses the inflammatory cascade. It prevents rejection of the embryo. It prevents autoimmunity. So it supports the embryo implantation in so many ways. So progesterone is given either in the natural micronized form or synthetic form. Natural micronized progesterone, it can be given orally, transdermal, intramuscular, vaginal, or subcutaneous. So orally, natural micronized progesterone, the bioavailability is very poor, less than 10%, and it has very high pass metabolism. So if we give high doses, then there are a lot of side effects. So we don't prefer giving micronized progesterone in the oral form. We usually give by transdermal. We usually give by intramuscular. Transdermal also in skin, there will be 5-alpha reductase enzyme, it will be inactivated. So it is not very effective orally or transdermally. So the most common preparations which we use are intramuscular and vaginal. Intramuscular, the dosage is 50 milligrams per day. It is very effective. Highest physiological levels can be achieved with intramuscular preparations, but the only disadvantage is it causes a lot of pain, inflammation. In some cases, if we give repeatedly, it might even lead to abscess formation, but it is most effective. And vaginal tablets, we can give it in the form of vaginal tablets, suppositories, or it is even available in the form of 8% gel. So it has high first pass uterine effect. So it achieves high endometrial level. So vaginal preparations are also very effective. And we can give subcutaneous in the form of aqueous progesterone, which is well tolerated compared to oil-based intramuscular injections. So coming to dydrogesterone, it is a synthetic isomer of natural progesterone. It has very good bioavailability orally, and it has selective action on progesterone receptors. It has no androgenic, estrogenic, or corticoid effects, and it is better tolerated than oral micronized progesterone. It has very high receptor affinity also, so dydrogesterone is very effective. We use it for all IUA cycles as well as in IVF cycles also we use dydrogesterone. The dosage is 20 to 30 milligrams per day. We often use TID dose only. So overall, the evidence is progesterone improves outcomes in IUA as well as IVF cycles. Multiple systematic reviews and meta-analysis also support progesterone supplementation in improving clinical pregnancy and live birth rates. So we can use vaginal intramuscular also. Vaginal is widely used. Intramuscular, in some cases, if we are not getting adequate progesterone levels with other routes, we can add intramuscular progesterone because it is painful and may lead to abscess formation. So it is often guided according to patient tolerance and local practice and type of cycle we are using. So in IUA or natural cycle, vaginal progesterone increases clinical pregnancy rates, and intramuscular progesterone is superior over vaginal progesterone, but it is of uncertain evidence. Subcutaneous progesterone, it is a newer option. It is easier administration compared to IM and comparable efficacy in several trials, so it can be used. Coming to HCG for luteal phase support. So HCG, the pros and cons of using it. HCG is like surrogate for LH. So it provides LH like support to corpus luteum. It has longer half-life and higher potency, and it is effective in maintaining luteal function, and it has similar pregnancy outcomes compared to progesterone. But it is not used as a sole agent. HCG we actually won't give in all cycles. Only whenever there is corpus luteum, then only HCG will be of benefit. In a HRT cycles, providing HCG will not be of much benefit, and it is not used as a sole agent. And it requires injections, and it is not recommended as first-line luteal phase support. And also in high responders, we should not give HCG because it increases the risk of OHSS. Progesterone alone is safer in such cases. Coming to GnRH agonist for LPS, GnRH agonist, the mechanism is it stimulates LH secretion from the pituitary and supports corpus luteum. And agonist also has direct effects on the endometrial GnRH receptors. So, and it also has direct effects on the embryo. So, it supports the embryo implantation and increases the success rates in IVF and IUA cycles. So, single dose of agonist decapeptydyl or any other agonist we can give around day 5 to day 6 post oocyte retrieval, or in IUI cycles after day 5 to day 6 after trigger we can give single dose of decapeptydyl which can improve success rates. So it can be given subcutaneous or intramuscular. Even Cochrane also supports the use of agonist for LPS. It has to be used along with progesterone, increases live birth rate and ongoing pregnancy rates. Like when compared to progesterone alone, when used with agonist, it improves live birth rates as well as ongoing pregnancy rates. Although mechanism is not very clear, it has direct effect on the endometrium, and it binds to GnRH receptors in the endometrium and supports embryo implantation. So coming to estrogen in luteal phase support, the role is in FET cycles, it primes the endometrium, especially in donor egg cycles. Whenever there are no follicles, we support with estrogen. And but it compensates for the lack of endogenous estrogen and improves receptivity. The dose of estradiol is we start with 4 to 8 milligrams per day, and it should be cautiously used in patients with risk of venous thromboembolism. And it can be used as transdermal gel or patches. But in hot and humid climates, the absorption is less with transdermal route alone. So we can mix up with oral as well as transdermal route. There's no fixed protocol. We do according to the patient's endometrium. If it is thin, we start with high dose. If it is normal, we can start with 2 mg TDS. So it should not be used for more than 40 days, which causes breakthrough bleeding. Usually 10 to 14 days we'll give estradiol. Then if the endometrium is adequate, we can start with luteal phase supplementation. So in the luteal phase, there is, according to Cochrane, no clear benefit in adding estrogen, but usually we prefer to add in HRT cycles along with progesterone. So timing, when to start luteal phase support. If we plan for fresh transfer on the day of oocyte retrieval, that day itself from the evening we can start luteal phase support. In FET, if it is a day 3 embryo, 3 days of progesterone, plus 4th day transfer will be there. And for a blastocyst embryo, 5 days of progesterone. On 6th day of progesterone, transfer will be there. It has to be continued until cardiac activity, until 8 to 10 weeks we continue. So monitoring the progesterone levels. Whenever we start progesterone on the day of transfer, it is not routine that we check progesterone levels, but we can check. It is less than 10, we can change the type of preparation or we can modify the protocol. But it is not a routine to do, but we can do. So LPS in natural cycle FET. In true natural cycle FETs, there is corpus luteum and it secretes progesterone. But increasing evidence suggests that few people have low luteal serum progesterone even with natural cycles. So we do consider to add few luteal phase support without, rather than adding nothing, we tend to add low doses of progesterone in true natural cycles. In artificial cycles like programmed FET cycles, there will be no corpus luteum. We are adding estrogen externally, so exogenous progesterone is required. So we give intensive luteal phase support in all programmed FET cycles. So in fresh transfer also we should add progesterone. Adding estrogen is not routinely supported by strong evidence. If agonist trigger is used, then we can add progesterone also, because we need more luteal phase support with agonist trigger. So this is from a Cochrane study. So HCG or progesterone given during the luteal phase may be associated with higher live birth rates. So we can consider HCG also, but it is not useful in HRT cycles. So these are the common preparations along with the dosages. Estradiol 2 milligrams TID. We can use either estradiol valerate or hemihydrate. Progesterone we can consider adding 8% vaginal gel, or it can be used in the form of capsules, or we can add oral dydrogesterone 10 milligrams TID or QID. Injectable preparations we can add 100 milligrams per day, and water-based preparations, it is available in the form of aquasustain 25 to 50 milligrams per day. And we can even consider adding GnRH agonist. We can use leuprolide 1 milligrams or 2 milligrams stat, or triptorelin 0.1 or 0.2 milligrams. So these are the adjuvants which we use in few special cases only, not as a routine. In cases with RPL and RAF, we tend to add a few of these medications like intravenous immunoglobulins, inhibit NK cell production by altering TH1 TH2 ratio, and anti-TNF alpha agents. We use this in recurrent implantation failure cases. And also intravenous lipids inhibits TH1 cytokines and reduces the cytotoxic effect of NK cells. Routine use of intralipids is not recommended, but in few cases we add intravenous lipids after embryo transfer. And we can use steroids also. They provide anti-inflammatory and immunosuppressive activity and improves the intraendometrial milieu for implantation. So we can add corticosteroids. And in few cases we add, almost all FET cycles we add aspirin. It increases uterine blood flow. It enhances endometrial receptivity and improves implantation rate. And low molecular weight heparin we can add in few cases with documented thrombophilias, or in women with RAF we can add low molecular weight heparin. It has antithrombotic effect, increased incidence of, but there is increased incidence of thrombophilia in women with RAF. It reduces the formation of microthrombi at the implantation site, so it improves the outcomes in women with thrombophilias. And metformin we can add in PCOS patients. Myoinositol also we can add in PCOS patients, and we can add probiotics and ellagimen. So the take-home points are luteal support is essential in ERT cycles due to luteal deficiency, and progesterone is the mainstay of support. We can give vaginal, subcutaneous, or intramuscular progesterones. Oral micronized progesterone has poor bioavailability, so it is not preferable, and dydrogesterone is very effective. And HCG is effective, but there is a risk of OHSS, so we need to be cautious while giving HCG. In high responders, we should avoid giving HCG, and we can give agonist along with progesterone to improve outcomes in low doses. And estradiol, the role is unclear, but in HRT cycles it is helpful. And in agonist trigger cycles, modified luteal phase support, like we need to give intensive luteal phase support with estradiol, progesterone. We can add low dose HCG also. In IUI cycles, it is beneficial in gonadotropin stimulated cycles, not in clomiphene seated. We can give for letrozole stimulated cycles. We can add LPS, and it has to be continued till 8 to 10 weeks. And the protocol of LPS based on the patient profile, type of trigger, whether it is fresh or frozen transfer, based on that we have to decide what to give. So most of the cycles we do here is frozen embryo transfer cycles, and most of the cycles are HRT cycles only. But we should prefer doing more and more of natural and modified natural cycles, because in those cycles corpus luteum will be present, which secretes progesterone. So the luteal phase support which we need to give will be less. So we should more and more try to convert for natural cycles. We prefer doing HRT cycles here because it is more convenient to do, and we can regulate the endometrium properly. So we prefer to do HRT cycles, but in few cases, natural modified natural cycles gives better outcomes. And use patient-friendly LPS. Like we should try to give vaginal, and we should try to add vaginal and oral progesterone, and reserve intramuscular for cases, selected cases or intolerant cases. We should add IM. And patients with OHSS try to avoid HCG, and individualize based on the progesterone monitoring history and patient preference. So in our center for natural or IUI cycles, we use dydrogesterone BD for 14 days after IUI or after trigger. And in cases with thin endometrium, we can add Estracet 2 mg BD or TID. This is the luteal phase support protocol for IVF cycles in our center. We use 100 milligrams IM twice weekly or weekly once. HCG is optional. We can add weekly once. And dydrogen, that is dydrogesterone 10 milligrams TDS we give. And endofert also the same dose which we start for HRT, we will continue the same dose of endofert. And we'll give vaginal progesterone BD or TID. And we'll add one dose of steroid in few cases, and ecospirin as a routine we'll give for all the cases. And in few selected cases, we'll add ivaparin also. So, thank you.